Managed Care Technical Assistance Team, otherwise known as MCTAC, and I'm joined by a number of partners from OMH today who are going to walk us through the content for this webinar. Just very quickly, logistics. We are recording the webinar today. We are also going to distribute the recording along with the slides following the webinar. For questions today, we're doing things slightly different. We are going to ask you to actually, we'll unmute you if you have a question. So what we're asking is if you look at your chat box functionality on the right-hand side, you'll see that there's the option to select raise your hand. So if you have a question, please raise your hand. We have time set aside at the end of the presentation where we'll be saving time for questions and our state partners will be responding. If for some reason you're not able to get in your question, please just chat it in to all panelists. I have a colleague on the line as well, Kevin from MCTAC. He's collecting all of the questions that we'll also be able to share with our state partners. So if for some reason you don't get a chance to have your question answered, please chat it into us so that we can share it with the state. And then lastly, I want to just say for all of those who are joined via, you're logged in via your computer so you can see the slides, what we would recommend strongly is that you call in for audio connection. It does seem to be working better than direct computer connection today. So just wanted to give that as a potential technical assistance recommendation. And with that, I think I'm going to pass it along to Emil, who will take us through some of the beginning of our slides. Emil?
Thank you very much. Hi, this is Emil Slane, Deputy Commissioner and Chief Fiscal Officer for OMH. Good morning. We wanted to have a webinar to give you more insight into the guidance we issued last week and to work closely with the counties on state aid flexibility. So the purpose of this webinar is to get you some more details on OMH's intent regarding state aid flexibility to support the community mental health system during this emergency period. We believe that flexibility will be useful for both the counties and the providers to utilize available state aid resources to address some of these unplanned and unbudgeted costs. Please know that OMH is fully committed to partnering directly with the counties and the providers to ensure that this flexibility will help address some of these challenges during the emergency period. I think our shared goal is preserving access and continuity of care to every extent possible and addressing some COVID expenses to preserve operations and community infrastructure. What we said in the guidance, and we'll go into some more detail here, and we'll explain how we will respond and act on waivers, as well as post information so that all counties and providers can see the guidance on this. But OMH is prepared to approve waivers to state aid contract requirements, and that includes waiver of specific guidelines, as well as supporting temporary interchanges between programs and funds to ensure that funds will be available to address COVID-19 response costs. We will explain this process further during this webinar and give you some examples for the counties, and as Megan said, open up the mic and address some specific questions you may have so that the entire DCS team and county team can learn from that. As you know, all of the OMH funding sources have different requirements attached to it. We call them the spending plan guidelines. These requirements contain certain standards and rules for the different programs and funding streams. OMH recognizes that the COVID-19 emergency necessitates flexibility in the use of these resources. And what we mentioned in the guidelines is just a few examples, which you see on this slide. It's not a comprehensive list. We are trying to give you some examples of things that we are open to flexibility on, including occupancy standards for residential programs, service utilization for certain care management programs, and other metrics and work plans, interchange flexibility between programs and funds, interchange flexibility between budget categories. Again, this list is not intended to be exhaustive, but it's to give you some examples of the types of waivers that OMH would entertain to assist the field. We will respond to any questions being submitted on this, including specific requests we get. And whether or not we respond to your specific question, you could send them in. What we're going to be doing is issuing a FAQ document following these webinars and posting these on the website so it acts as a resource for counties and providers regarding the flexibility. That document will be updated regularly and will help the field operate under this flexibility. The flexibility will apply to the 2019-20 period in New York City. It'll apply to the 2020 period in upstate counties. As a general principle, we're assuming that LGUs and providers are following the OMH guidance, the state and county health department guidance related to COVID-19. As I stated, our goal is really to preserve access and continuity of care to every extent possible and to address some of these COVID-19 expenses and preserve operations and infrastructure. OMH wants to ensure that the community providers are educated and supported on appropriate public health responses based on the science here. Just one example is we'll be conducting webinars for residential programs based on some of the infection control guidance that we recently issued. So part of the providers' responses here, and we put this example in the guidance that's up on the slide, is that providers may need to temporarily shift some staffing resources from a lower priority program that may have closed to a higher priority program that requires 24/7 staffing and requires additional resources. You know, we listed an example on the slide. We believe that that is a logical response and a good example of the intent of the state aid flexibility that we're laying out here. And we want to make sure that providers and counties can navigate any questions on that. A little bit in terms of process, because I know process is as important as any policy. We will be working to respond to any request for flexibility in a timely manner. Our goal is to support the LGU partners as well as the providers in navigating this. When a specific request for flexibility or assistance is known, the LGUs and or the providers can submit an email to the field office. What we would request is that that specific request or email should include some details on the purpose, the type of flexibility needed, and specific state aid funding reallocation that's being requested, and how that ties to the COVID response in the community mental health system. So we would like those details to be framed in an email so that the field office and the central office can review and respond in a timely manner. Our goal is to turn this around quickly. As a goal, we would love to be able to turn this around in one business day. That's kind of our goal that we would shoot for. The specific detail in the request and the requested flexibility is critical so that OMH can ensure that any approved request will be fully honored in the closeout process. We want to make sure that the resources stay consistent with the waiver request and the intended plan. Going through this process will ensure that the county and the provider has full assurance that those resources and allocations out there will be available, consistent with the flexibility requests that you may be submitted. We listed some examples in the guidance that we issued already. We'll give some more examples here based on some of the requests we've already received from counties and or providers. So some examples are listed on this slide. We've gotten some requests where LGUs have requested to temporarily reallocate funds on state aid letter between certain programs or funding codes, funds that may be unallocated to address provider-specific COVID needs. We've gotten some requests in terms of contract flexibility to reassign staff and funding between programs to maintain essential operations. As you know, we've issued infection control guidance for residential programs. Many residential programs have cited expenses with cleaning, disinfection work. So that is a logical area that we know flexibility requests will come in. Also on the personnel side, the challenge of maintaining staffing for core programs that aren't shut down during this period. So those are logical expenses. And another major area that we know providers are investing in is one-time cost for telehealth setup as they try to continue care with patients in some fashion using telehealth consistent with the OMH guidance. I think the key thing in this entire process is that counties and providers understand that all these requests are within the current available state aid contracts and state aid letter allocations. We want to pursue, flexibility here to ensure that these resources are fully available and utilized. But the dollars that we're talking about here are within the current instrument and current allocations. I think the other key thing that LGU should understand and the provider community should understand, and we have Gary Weisskopf who's going to present a little bit more on this, but the guidance that we issued related to state aid really applies to state aid funded programs that are under the contracts held by the counties or held by OMH. For Medicaid programs, we've already issued guidance on telehealth, and Gary will talk a little bit more about that, but that's been a way for providers to continue continuity of care and collect revenue for patient care. We know that, there are various challenges with that, and the other thing that OMH is pursuing is further Medicaid actions. We have an 1135 waiver to preserve access to needed services, and Gary's going to talk a little bit more about that. Because the key on the Medicaid side is we want to pursue maximum flexibility and ability to continue services and care, and for providers to be able to bill for revenue to mitigate some of the revenue loss. So I'm going to hand over the presentation to April, who's going to talk a little bit about some of the other actions that we're taking on the contract side and the state aid side.
Thank you, Emil. This is April Wojtkiewicz. I'm the Director of Community Budget and Financial Management here at OMH. And I'm going to walk you through some of the reporting deadlines and so forth that we've been talking about in the guidance we issued last week. The first thing that most of you are probably already aware of is that we did issue guidance extending the CFR deadline for calendar year filers to August 1st. We issued that last week. It was sent out to all providers via email. Hopefully you did receive that. If not, there is a copy of that on our website as indicated on the slide in front of you. Just, so everyone knows that that was done fairly quickly, and we'll continue to reassess, time frames as this crisis continues to evolve. That guidance was specific to OMH, but my understanding is the other O agencies did issue guidance as well, so I would, refer you to their web pages for that guidance. The other thing you should know is that in terms of contracts and payments, what we did do was we did not withhold any recoupments. So for any providers or counties that had withholds related to a prior year recovery from underspending or some other disallowance, we undid those. So you may have actually gotten two payments. We had triggered payments initially and then had to go back and undo withhold. So you should have received a full quarter payment for the April quarter. Those payments are going out this week. I believe most of them have been dispersed from the state treasury. If that is not the case, please do reach out to me and let me know, and we will address that as soon as possible. Next, I'll talk a little bit more about payments and closeouts. In our guidance, we did a couple of things. One, as I just indicated, we've gotten all our April quarterly payments loaded, and they should be dispersing now, so you should be seeing those in your bank accounts. We did that for both direct contracts as well as state aid letter allocations. We have already put in place systems here so that we will be able to continue to make payments as contracts and allocations are made via state aid letter, so there will be or should be no delay between the time an action is approved and the time that we get it loaded and into the system for payment. So do know that payments will continue to flow even during this time that we're facing at the moment. We are also in the process of ensuring with our staff that any contract renewals and amendments continue to go through the process. We're trying to expedite those as much as possible. We do recognize that there are a lot of people who have changes in their contracts, and those do result in more cash flow for the agencies, so we are working to make sure that those continue to move as quickly as possible. Excuse me. In terms of technical assistance, we're more than ready to help you. The field offices are obviously your first line of contact and are there to help you in any way they can, as well as myself and my staff. Although we may not be sitting at our desks, we are all working from home. So if you have any difficulty reaching out, please do email as well. Sometimes that gets to us a little bit faster than phone calls right now, but please do reach out. We are trying to help anyone and everyone as issues come up. In terms of closeouts, we also mentioned in our guidance last week that we are temporarily going to suspend issuing all state aid closeouts and contract closeouts. So you will not be receiving any kind of notification from us on a prior year state aid letter or contract. We're going to hold those so that you can focus on the work that needs to be done now. And, you know, if you have any questions about that, please feel free to ask. In terms of audits, although I'm not the agency auditor, we are holding on any current audits. We're going to grant extensions on any current responses that are due, and anything that is currently underway will be temporarily suspended so that your teams can focus on the work at hand. Any opening conferences and new audits will be postponed until further notice. And if, excuse me, once the suspension is lifted, each provider who was undergoing or in the midst of an audit or will be be audited will be contacted after we lift this suspension. And
great, thank you.
I'm going to toss it back to you, Emil.
Okay, we did include in the guidance a reference to reporting and the discipline of trying to track any COVID-related expenses. We don't have any specific guidance on that at this time, but we are just encouraging it because you may have been following that FEMA has declared New York as an emergency related to this, and it may provide an opportunity for relief similar to Hurricane Sandy and other times we've been declared an emergency. So what we're advising is that providers keep track of these expenses that may provide for an opportunity down the road. We're not aware of any specific funding streams at this time. If there are extraordinary situations, so we've had those experiences in Hurricane Sandy where a few providers may have needed hands-on OMH assistance to deal with a very complex response. We encourage those providers and/or counties to reach out to us so that we can work with you. An example in Hurricane Sandy was we had to relocate some residences temporarily. So we're really talking about extraordinary situations that you may be interested in additional OMH support and guidance. We will partner with the community providers, with the counties, in navigating such extraordinary situations. I'm going to hand it over to Gary on talking a little bit about the additional flexibility, which is so important because we strongly encourage all the Medicaid programs to pursue continuity of services and billing on the front end. We think that that's important not only for patient care, but also for revenue to support ongoing costs.
Thanks, Emil. Can we go to the next slide? Can you hear me? Okay, great. So just to echo what Emil was saying is that we're really trying hard to give as much flexibility as possible to allow continuity of operations during this time. Some of the flexibilities that we've already given are listed in the FAQs and the guidance that's on our website. You'll see a link to that coming up. We are continuously working on trying to answer a number of questions and get more guidance out. So just keep checking the website. I know it's very hard with everybody's schedule. I'm going to go over some of the major ones that we're working on and some of the things that we've asked the federal government for. So first of all, really one of the biggest ones is that we've extended telemedicine to include telephonic, which is a really significant change that allows people to work even if they don't have the investment in place to do video and audio bidirectionally. It can be done from any of the locations where the employees are working from and to any location where the recipient of care is. So that's something that's really important, and it's important to pay attention to. There's a lot of guidance and FAQs on it. It does need to be billed using the same modifiers that we use for audio video, so we can keep track of the volume of these calls, and this waiver is in place for the duration of the emergency situation. There's also several staff flexibilities that have been put out. These can be found, again, in guidance and also in the frequently asked questions. For example, in the CCBHCs, in lieu of the RN requirement, we're allowing an LPN to work. Documentation flexibility, some of the questions we've received about how do I get consent from the recipient. A verbal consent is okay. We ask that you document it in progress notes and again, for treatment plan signatures, more of this, I keep pointing you back to the FAQs because there's more specific examples, but we recognize that in-person signatures is just not going to be possible at this time. We're working on a number of billing flexibilities and reviewing whether we can do anything with the time requirements that are allowed and the face-to-face requirements so that we can recognize that it's just impossible to get the people on the phone for, say, 45 minutes in many cases. So what can we do about that? And we're taking a look at it right now. We're looking at and planning to drop face-to-face requirements so that they can be done by telehealth as opposed to in person. Will count as face-to-face, and telephone will count as face-to-face. And then EasyPAR is not necessary to change office hours. And in order to do telehealth, and this is really important, all it is an attestation for the agency submitted to OMH and then nothing more is required. You don't need to get any more permission from OMH. You can just keep on going. So providers will want to know that as well. We can go to the next slide. So New York State submitted an 1135 waiver to CMS. This is a waiver that when the president declares a national emergency, the federal government can waive a lot of rules and regulations that they otherwise can't do. So the state has requested a lot of broad authorities for this. We don't know whether we're going to get approval for them, but I'll give you some examples of the things that are in the 1135. The ability to do clinic offsite. We have that in Medicaid managed care. We don't really have that in fee-for-service. Verbal authorizations for services. You heard me say we're already doing this, but we want consent from the federal government. Broad flexibility to target rate increases and supplemental payments and reimbursement changes. So this is really important because we know that a number of providers, if you bill monthly or your day programs or even clinics, are not going to have the volume that they had or not be able to have people coming in, not being able to do groups very effectively. And we want the ability to target reimbursement specifically to those providers so that we could try and hold them either at whole or as close to whole as we can, even if they can't do the volume of services during this time, because we want to make sure that the workforce and the provider safety net community is still there after we get out of this emergency. So hopefully we're going to get that federal authority so we'll be able to do some of that. Also, we told managed care companies, Medicaid managed care companies, that they can't put on any contract requirements or anything additional in order to pay for telehealth. It's the same as face-to-face. So if we hear from providers that they're having problems, we will follow up on that, but they've been instructed not to do that. The Department of Financial Services has told also all commercial managed care plans that are under state authority that they also must pay for telehealth. It's a little separate from the 1135. We have guidance out for housing providers. So there are a lot of things that are in this 1135 that, if it's approved, will give us great flexibility in how we reimburse providers and how we determine the length of services. So more to come on that. And we will continue to outreach to everybody and update the frequently asked questions once we know more. And so we can go to the next slide. And just this is really important because this is where OMH publishes their guidance. DOH is also publishing a lot of guidance on their website, which is important to keep in mind. One thing is that often our guidance is particularly targeted to mental health programs and may look different than the guidance that DOH has. So we've put notes on that, and we're trying to make sure everybody understands that when it comes to a mental health program that's licensed, funded, or designated by OMH, you need to follow the guidance that OMH puts out because we have additional flexibilities that don't necessarily exist in the DOH guidance. And DOH is aware of it, and this guidance is, it's been approved by the governor's office. So just want to reassure you that following the OMH guidance is really what should be done for our programs. All right, that's all I have.
All right, well, thank you, Gary. This is Meg. And now I think we're going to move to our question portion of the webinar. So just as a gentle reminder, we're asking folks to raise their hands virtually, of course. There's a button on the right-hand side of your screen. It's tiny. It looks like a little electronic hand. And what we're asking you to do, if you have a question right now, is to click that button. My colleague, Caitlin, who's the MCTAC host, is going to call your name out, and that means you're about to be unmuted. So what we will ask you to do then is just to make sure you're actually unmuted on your phone, that you haven't muted yourself, and that you could ask your question out loud. The other thing is just to be safe, because we have some time to answer these questions, but are not sure we're going to be able to get to everyone's question. If you could also chat in your questions to all panelists, we're collecting them that way. So thanks again. And I guess, Caitlin, we will get started. So folks, if you want to raise your hand, please do so.
Yes, so we have our first hand raise is Karen Monroe. Karen?
Hello. Hi, can you hear me?
Yes,
yes,
Hello?
we can. Mm-hmm.
Okay, great. So I'm trying to build the billing rules for these new telehealth services based on the Medicaid Update Special Edition and having looked at the OMH website. And I'm stuck on the modifiers. There's a table, and for 95, it refers you to the AMA CPT Professional Edition 2018 Codebook, which I don't have available to me. And
Right.
I'm wondering, is there anywhere out there?
Yes, that's a really good question, and we got this question from many people. So we have a table that's being put together, and hopefully we'll get on the website today or tomorrow that will identify for each procedure code which modifier you would use. These are the procedure codes that are in OMH clinics. We clearly, if you're using, if you have an OASIS program or a DOH program, these procedure codes and these modifiers might look a little differently for other payers and other programs, but the table will be for OMH programs and for a clinic, which procedure code, which modifier. Does that answer your question?
Yeah, yes, but I'm just hoping that it's like pretty detailed, like it'll say for like an individual service versus like for a doctor med management service. Will they be giving out, okay?
It will have, yes, whatever procedure code that we use in our clinic, it'll have the procedure code. I don't know if it has the service name next to it, but I guess we can put that there too. But it would have the procedure code and the modifier. And so you'll be able to easily identify which modifier to use.
Perfect. Thank you.
Yep.
All right, so just a reminder to raise your hand. I see some people are chatting in questions, but please also raise your hand so we can unmute you and you can go live. Okay, so James Hatt. James, you're live. James, if you're muted on your phone, just make sure you unmute that, or on your computer. Okay, so James might be having a little technical difficulty, so we will come back to him. Just keep your hand raised. All right, so we're going to go to Lauren Lagoya. Lauren?
Hi, This is Lauren. I only had 2 questions. So one, April spoke to the funding coming through to the counties for LGUs, and we did just get all of the state funding. My only question is, do you guys have an idea of when we'll get the federal portion of those funds?
So this is April. That funding should flow as long as the county has filed the federal certifications that are required. So I can go back and double check to see that all counties receive their federal funding. That was my understanding, but again, that would not happen if the county had not filed their federal certifications. But I will double check. I don't think we were in that position, so it may be a timing issue. It may not have hit the system just yet, but I will verify that it is moving.
And my second question is related to the need for like equipment purchases. So we have our own kind of form and process for when our providers in Monroe County have a request to purchase equipment over $5,000 that we then work with the field office on to fill those out. Will this new form related, new process of the purpose, the type of flexibility needed, and the rationalization of the request and how it's related to CBOID kind of replace that one in the interim?
I think they're certainly interchangeable.
Okay.
I think you go the fastest path. So if your normal process works and you could deal with it through the funds you have available on the state aid letter, and that's the fastest path, we would encourage counties to do that. If you need OMH's assistance to move around money on the state aid letter, if you have unallocated funds and you want to make sure that you're making available purchases that may be needed pursuant to COVID-19, we will help you do that.
Okay, perfect. Thank you.
All right, so any other questions, people? Just raise your hand. Okay, so we have a question from Brenton Moore. Brenton?
Yes. The question was just a matter of clarification. Is there a waiver or is there guidance regarding the treatment plan signature requirement from the doctors?
Could you repeat the question?
Sure. Just looking to know if treatment plans are still due to be signed within the regulations by the docs as they currently were before the COVID-19 outbreak.
So I'm sorry, there is in our FAQs, there's an answer to that question, but I don't remember it, so we will look it up and get back to you, unless we have any of the program people on. There is an answer to that question. So we're recording it, and we have your name, right, Meg?
We have his name, definitely.
Yes,
okay, so we can get back to you. Thanks.
Okay, thank you.
All right, we don't have any other hands raised at this time, so just a reminder, raise your hand. We are getting a few questions into the chat, so we could address those.
Would the state partners like us to read some of the, sorry, Caitlin, do you have a raised hand?
Okay. No, I was just going to ask if they want us to read some of the chatted in questions.
Love it. We're mind melded. What do you think, state partners? Would you like us to read some of what's been chatted in?
That sounds great.
Okay.
Okay. So from Jill Tibbett, we have, do the state aid programs need to submit a waiver attestation to the telemental health like the billing programs do?
I think what we're trying to do is ensure that there's an avenue that if counties are waiving contract requirements for certain services, we want to make sure that the state's documenting that flexibility exists, that no one later is going to come back and audit and zing any provider or county. So to the extent that the county feels like it needs to document a specific situation where you have a work plan with certain deliverables that won't be met because of these circumstances, and the county wants to document that, they can document through the process, but know that OMH is going to be reasonable throughout this process, both on the front end and on the back end. We're not going to go in and audit any state aid technical waivers on the program deliverables. We do encourage you to articulate what it is you're waiving on a county-held contract.
Great. So we have another question from Lisa Sato. Any idea how soon CMS will approve the 1135 waiver? Are they going to expedite?
So there's conversations going back and forth with the state and CMS. They've committed to moving fast. They're probably going to have questions for us. I don't think it'll be really long, but I can't guarantee anything.
Okay. Looking through the questions. All right, from John Greco, if the state aid flows to the LGU for the contract, does the waiver request come to the LGU first?
We are assuming that the counties will exercise the same logic and approach in terms of flexibility on the contracts that you hold and manage. If you want additional state support and guidance on that, or need assistance on state aid letter reallocations, you could reach out to the state and document what you're doing through the process that we're describing here. But we understand that you guys do hold the contracts on the front lines. In some instances, that the providers are going to be coming to you articulating, the flexibility that's needed. We also understand that some providers may go directly to the state, in which case we will loop in the county and work together on ensuring that we're fulfilling the intent that OMH is rolling out here.
Okay, we have another question from James Hates. We know Medicaid and Medicaid managed care organizations are allowing 90-day prescriptions. We've received denial from private insurance companies for 90-day prescription supply. Anything you can do about that?
Gary, do you want?
We'll look into it.
Yeah,
I think
this is important. Yeah, we appreciate this question. The Department for Financial Services actually issued guidance in some areas of insurance coverage, and as Gary said, this is helpful feedback, and we will look into it.
Great. So that's all the questions we have in right now. Just a reminder for people to chat in questions or to raise their hands.
I think we'll give it another minute or so, but I do want to thank all of our OMH colleagues who joined and presented on this, and all of our attendees who joined, asked thoughtful questions, chatted in thoughtful questions. I know we're going to be distributing the recording and the slides soon, and I know MCTAC is going to share the questions that we collected with the state. So if we weren't able to get an answer, I know for like that one question, we'll be able to follow up about that. Anything else? I'm not seeing any other questions that have been chatted in. Caitlin, do you have any other hands raised on your end?
No other hands raised right now. Yeah, no other hands raised.
OMH colleagues, anything else you would like to add or recommend at this time, or let us know?
This is Gary. I would just strongly encourage that people monitor the frequently asked questions. We're putting them out as frequently as we can. As we get them in, there's a lot of information in there, and the links are in the PowerPoint, which I think is going to be sent out to everybody.
Yes, it will.
Yeah.
Great. And this is Emil. I want to thank all the counties for their partnership here in this challenging time. And a lot of the questions are clearly focused on Medicaid billing and preserving revenue. And I think as we get action on the federal 1135 waiver, we will be setting up, another session like this, right? So thank you so
Bob
much.
Myers wants to say something before everybody hangs up.
Excellent.
Go ahead, Bob.
Hi, this is Bob. Realizing that we're talking with the county directors, this isn't about the fiscal guidance, but I wanted to raise something else because I was just on the monthly call we have with the medical directors for the managed care plans. And the plans say that they're hearing from providers in their network, the outpatient programs, that they're closed to new admissions. When we put the telemedicine guidance out there, the first webinar we had with the providers, we said that the reason we approved you for telemedicine wasn't so that you could close, but that you could do services virtually when appropriate, including new admissions. You shouldn't say you're closed, and you certainly shouldn't say you're closed to new admissions, because that'll back up the whole system for new people that need care, for people coming out of higher levels of care. And then we've emphasized that in our guidance. There's a guidance document that talks about that. We're also asking clinics to not close completely, but have a minimal on-site presence for people that need that and to do injectable medications. I'm sure that counties are also hearing this, and some of the plans said they had been talking to the RPCs, et cetera. So I just wanted to let you know that outpatient programs, especially clinics, shouldn't say that they're closed for new admissions or that they're closed, but that they can provide the service virtually, including, when appropriate, they could take a new admission virtually to try to determine what support the person needs to transition from whatever level of care they're coming from, or if they've been identified in the community, and that there has to be a pharmacological approach too for the medications. Thanks.
Thanks, Bob.